Welcome, everyone. I'm Catherine Pierce from the NTG. We started a couple of minutes early to give people time to get on. I am going to put a poll up on the screen here and would appreciate it while you're waiting for us to get formally started right at the top of the hour. If you would just take a minute and answer these two quick poll questions, we would greatly appreciate it. So again, if you're just joining us, we'll start right at the top of the hour, but in the meantime, if you could just take a couple minutes and answer the two quick poll questions that you see displayed on your screen. I see people are answering. Thank you. I see we've got a few more people just coming on. We're going to start right at the top of the hour. In the meantime, if you could just answer those two quick poll questions displayed on your screen, we would appreciate your feedback. For those of you just joining, we're going to start right at the top of the hour in about a minute. But in the time we have between now and then, if you could just take a minute and very quickly answer those two questions that you see appearing on your screen, that will help us have a little sense, and Dr. Ezralou have a little sense of the experience that folks have with the EDSD. So very quickly, just answer those questions. And I have right at the top of the hour. So we will go ahead and get started. We do have more people coming on. As you're coming on, please just take a moment and answer those two poll questions if you would, while I just go over a couple of housekeeping things. And then in a minute, we will show those poll results to you. Lucy, could you go to the next slide, please? First and foremost, we want to put a huge shout out to the sponsors of tonight's webinar, Special Olympics. We are doing this webinar under a grant that we've received from Special Olympics to work on a CMS program, the GUIDE program. Some of you may have heard of it, to develop some technical assistance and other educational supports and so forth for GUIDE participants. We have done a webinar on that in the past, and I will put the link to that webinar as well in the follow-up email that you will get. But we want to thank Special Olympics for their support. Next slide, please. The handouts were sent out in advance. We will send them out afterwards as well. And I will put that link in the chat box once we get started if you didn't have a chance to download them. Next slide. Everyone is muted by default. When you do think of a question, don't wait. You can put that in the Q&A box if you would. In the chat box, use that for sort of technical questions or to communicate with the hosts. But put your actual questions in the Q&A box, put them in at any point, and we will take them at the end of the webinar. Next slide. And with that, I am going to turn it over to you, Helen Stepawani.
Well, good evening, everyone. I'm delighted to introduce our speaker this evening, Dr. Lucille Ezralou, who is the Senior Supervising Psychologist with the California Department of Developmental Services, as you can see on this bio slide. Let me share a little bit about Lucy Ezralou, who I have been privileged to know and work with for probably the last 15 years. Dr. Ezralou is a clinician, an educator, and a consultant. She's been particularly interested in building capacity for dementia-capable caregiving, building capacity to provide mental health and behavioral health services for individuals with complex health needs, and increasing the caregiving resources of families and staff who serve individuals and support individuals who are challenged by disabilities and dementia, or the co-occurring challenges of mental illness and developmental disabilities. We're particularly excited to have Dr. Ezralou tonight because she was one of a team of several individuals who worked to develop the NTG-EDSD. Dr. Eslulu really spearheaded that effort with her colleagues, and we are going to really reap the benefits of that work in tonight's webinar. So having said that, I'm happy to introduce you to Lucy, and I am going to just quickly turn back to Catherine to see if she has some early poll results. Catherine, what did we find out about those 2 poll questions?
Well, first question was, how familiar are you with the EDSD? And we've got a few people who are very familiar. That's nice to hear. Glad they're with us. But the majority are either somewhat familiar, they've heard of it but haven't used it, or they've never heard of it at all. So that was 43% are somewhat familiar, 47% not familiar at all. So I would say the majority of folks with us tonight are not that familiar with it. So we're glad to have you here to get the information. Second question was, are you currently using the EDSD in your work or organization? 13% yes, they're using it regularly. 13% occasionally or on a trial basis. 24% not yet, but we're interested in using it. And 51% are not using it. So with that, I will turn it back over to you, Dr. Ezralu.
You. Thank you, Catherine. Thank you, Helen.
Yes.
So this is a great opportunity for me to introduce you to the NTG-EDSD if you're not familiar with it, and review some things if you are. So what I'm hoping to accomplish in the next hour is to understand the use of the EDSD, the early detection screen for dementia, as a method of or an approach to identifying a person's cognitive behavior and functional baseline. And I'll talk about baseline in a few slides from now. I want to give you some tips on how to complete the screening tool in order to capture your observations of change. And I hope to get around to 2 scenarios, David and Sarah. We certainly will get to at least one of those scenarios. You should have received or can retrieve both scenarios from the box and which had the PowerPoint slides. And you can, if you have them in front of you, you'll be able to follow along with me later.
And I just put them in the chat, the link in the chat box again, Lucy, for folks.
Very good. Thank you so much, Catherine. And I want to consider how to apply the findings from this tool to communicate within the team, the IDT or the multidisciplinary team, to inform decisions for a person about services, care, and supports. So what is the National Task Group Early Detection Screen for Dementia? Well, it's an administrative screening tool. It can be used to baseline a person's behavior across multiple domains of functioning. So how do we see this tool used? We see it as a way of capturing observation of change, which reflect a significant departure from how the person has typically functioned. It can help us advance important conversations about that change within the interdisciplinary team, or if you call your team a multidisciplinary team, and advance those conversations with healthcare providers. And it can be used to inform decision-making about a person's care, services, and supports. So again, it's a communication tool that aids decision-making. And here's a very important point that I want to emphasize. It is not a clinical tool. You would not use the EDSD to get somebody a diagnosis of a dementia, whether it's Alzheimer's disease or another type of dementia, based on the ratings from this tool. The EDSD does not replace the need for comprehensive assessment. For instance, there is no scoring or cutoffs within the tool, and that is because it is not meant to get a cutoff point or to say a person meets a certain criteria. The person in question is never directly assessed with the tool. In fact, you can do this rating without the person in the room with you. So again, it departs significantly from what we would consider to be a clinical tool. Nonetheless, it is very useful for us in thinking about how to move the ball down the court in terms of a person's care and service needs. So why did the National Task Group develop the early detection screen for dementia? Well, early on, we heard from family and professional caregivers that something was needed, a tool or some way in which we could capture the information about change that people were observing and the people they supported and their relatives' changes in cognition, behavior, and daily functioning. So we wanted to provide caregivers, both informal, like family caregivers and professional caregivers, with a format in which they could share important information about a person they support, and also share that information about the individual with that person's healthcare provider. And we think it's a good tool in order to lift up those areas that are most important to observe in terms of change that might indicate dementia. So it was a way that we could use to train caregivers to recognize and report relevant signs of change. For those eligible, those 65 and older, the NTG-EDSD could be used as part of their annual wellness visit. So you hopefully have had a chance to retrieve from the box or from the chat the NTG-EDSD that I completed for David and Sarah. So we're going to look at it a little more closely, but this is just kind of a screenshot of it. It can be completed by family members, support staff, or other stakeholders to note the presence of key behaviors that we associate with the possibility of a dementia. So the important thing to note is, since it's not a clinical tool, it does not require that you have clinical training in order to administer this tool, in order to do the rating. It also picks up on health status, activities of daily living, ADLs, behavior and function, memory, and self-reported problems. So what I encourage you to do, if you want a blank template of this, not one that was filled out for the purpose of this webinar, you can go to the National Task Group site and you can pull up this tool. You can either do a paper version that you download, or you can use an electronic form, and it is available in multiple languages. I think at this point in time, we're up to 12 different languages in which it is available. So who would you use this rating tool to screen? Who can be screened? Well, any individual with intellectual and developmental disability, regardless of the cause of their intellectual and developmental disability. However, we do note a difference between people with Down syndrome and for individuals who do not have Down syndrome. Because of the known connection between Down syndrome and Alzheimer's disease, we recommend that individuals are screened at an earlier age. We know that once individuals are above the age of 50 with Down syndrome, they have a higher risk of developing Alzheimer's type dementia. So we're recommending that you would begin using this tool around ages 35 or 40, okay? And you may notice it says something different on the printed form. However, this is in practice what we're seeing is most helpful. If the person has another form of developmental disorder, let's say it's intellectual disability, autism, fetal alcohol spectrum disorder, epilepsy, cerebral palsy, but it's not Down syndrome, you can begin at a later age, and you might consider beginning the screening as of age 50 or when changes have been observed. So some tips for completing the NTG-EDSD. So again, who can administer it? It can be completed by somebody who is familiar with the individual. Obviously, family members could complete it, or staff that have at least 6 months of experience with the individual. So again, this is an administrative tool. It is used to help with decision making. It is not a clinical screen, okay? Where can you administer it? You can administer it anywhere, and it's suggested that it might be one way of doing it is to do separate forms depending on the different settings a person may attend. So if a person is in a residence as well as a day program, you might want the staff from the day program to complete, as well as staff from the residence or the family to complete it, a separate form. Or you might all want to get together and do this by consensus and complete a form. And what's needed is really just gathering medical and other background information that's usually available in a person's chart to fill out some of the questions that relate to medical and mental health status changes. So if possible, if the same rater can fill out the tool on a quarterly basis every year or however often is necessary until a diagnosis is confirmed, that could be helpful because sometimes different raters have different ways of approaching filling out the form. And you may want to mark or highlight items about which you're unsure and you want to check in with other members of the team. There may be some items you're not quite sure about, so you might want to get back to it later on. Once you have completed this, if you're a staff person, you may want to share the ratings with your supervisor or designated staff for team review. And you might want to summarize the findings from this tool for the individual's healthcare provider. So again, we're not expecting you're going to hand this to the healthcare provider. Usually healthcare providers are pretty busy. However, you can highlight some of the findings from the tool and share that with the healthcare provider. So here we come to the term that I used earlier, and I want to just emphasize this idea of baseline information. So what do we mean by baseline information and why is it important? So when we measure baseline, we're actually talking about what's usual or typical functioning for the individual. Like typically, on a usual basis, characteristically, how does this person perform in a certain area of functioning? This helps us recognize if we have a baseline, whether or not they are departing from their usual typical behaviors or skill sets. By identifying what is changing and also what remains the same, we have a better idea of how to tailor services, care, and support. So not all change from baseline is meaningful for our purposes. The EDSD identifies those areas or domains important to the recognition of a type of meaningful change that might alert caregivers about the need to follow up. And how might caregivers follow up? By bringing the information to the team and the topic of the client's change from usual functioning, or by bringing up to the client's healthcare provider changes from usual functioning, or by recognizing that more information is needed and additional tracking or an investigation of one type or another would be helpful. So here I have this little graphic that says, ask the experts. So you might think the experts are the professionals. So of course, professionals have expertise in evaluation of neurocognitive disorders, that is dementia. However, in this case, family and staff are the experts. You're the ones who know the individual the best, are in the best position to notice important and everyday changes in functioning. Now, individuals who are in the general population with typical cognitive development, we have a number of tools that can be used to see if, in fact, they have changes. But for individuals with intellectual disability, intellectual disorders, it's very difficult to use the standard tools. So we have to recognize significant change by comparing it to their baseline functioning. So just to review, you may very well know this, but dementia, which is a term that I'm using here, is an umbrella term. And it refers to multiple causes of cognitive behavior and functional decline. And you see that it's an umbrella term. There's an umbrella, and underneath it are different types of dementia. So Alzheimer's disease is the most common form of dementia, and there are certainly other forms of dementia, or what we call neurocognitive disorders, such as vascular dementia, very often having to do with stroke or changes in blood flow, cerebral vascular dementia, Lewy bodies dementia, Parkinson's disease dementia, and frontotemporal dementia. There are also conditions associated with change in adults in the domains of cognition, behavior, and daily functioning that could be caused by conditions other than a neurocognitive disorder. Not all change is due to dementia. So what do I mean by that? Well, I mean that there are a number of conditions that actually an adult can respond to by having changes in cognition, in behavior, or daily skills. And among this, and by the way, this is not the definitive list, there are other things we could put on this list. Depression can cause changes in functioning. Delirium, when somebody has a medical condition, delirium's a medical emergency, can cause a very altered mental status change. Sensory loss can contribute to difficulty processing information and can lead to confusion. Person may appear to have a form of dementia. Pain, particularly if pain is unaddressed, might contribute to changes in functioning, and extreme psychosocial stressors, where the person is overtaxed in terms of their adjusting to and adapting to stressors that they're confronted with. So all these things and more can cause changes in functioning. So, so what we want to do by giving the EDSD, you don't have to know in advance what's causing these changes. We want to capture what those changes are. And then the team can go about figuring out how to best investigate and take next steps with this. So we want to follow those changes in behavior that interfere with independent functioning, or diminish the person's quality of life, or get in the way of the individual's goals, such as independent living, the ability to work, or the ability to sustain relationships. And certainly we want to investigate and follow or track those behaviors that put the individual or others at risk in terms of safety, in terms of loss of programming, in terms of loss of placement. So what are some of the changes that you might observe? So one of the categories you'd see if you look at the EDSD has to do with adaptive skills. And there are a number of adaptive skills, and usually we think about adaptive skills in two main categories. ADLs, which are activities of daily living. That's feeding and toileting and dressing and bathing. And then there's a term called instrumental activities of daily living. And that has to do with some more complicated tasks, having to do with shopping or housekeeping, maintaining one's living space, handling medication, handling one's finances. So both of those are possibly impacted if a person, if we suspect a person has dementia. They may indeed show changes in a variety of these skills. So for instance, we may, with activities of daily living, begin to see balance and gait problems. We may begin to see what we call apraxia, difficulty sequencing daily activities, like getting dressed or feeding oneself or speaking. We might see an increased need for assistance with bathroom or personal care needs for grooming. We may see an increase in something like incontinence, urinary or fecal incontinence. In terms of instrumental activities of daily living, we may see difficulty handling money if this was previously a skill. Again, if the person didn't have the skill to begin with, we're not thinking of it as an area we're tracking for change, or difficulty maintaining one's living space, or using the phone or other devices. So another major area in the EDSD is observing changes of behavior. So what might you observe in terms of changes of behavior? Well, you might observe an increase in impulsivity. The person who either never had this tendency or may have had the tendency, and it gets worse in terms of hoarding and verbal and physical aggressive behavior. Increased reactivity to others. Maybe their social behavior does not match the social situations that they're in. And we may observe increased restlessness and agitation. And by the way, this is not a definitive list. There are many other things you might observe, but these are key among the things that people report, seeing. It also can be true in the icon I have here, apathy, which means that rather than seeing this reactivity or restless or agitation, you see the opposite, where a person seems to withdraw from their surroundings and not to care very much. What changes might you observe in cognition? So what do we mean by cognition? We mean abilities such as reasoning, paying attention, memory, language, learning, and perception. Now, when we think of dementia, we tend to key on memory, but very important to know that memory is not the only cognitive process that is impacted with dementias. So, of course, memory is something that you see in the general population. In the population of people with intellectual and developmental disabilities, sometimes that's not the change that you see first. However, let's just talk about what changes you might observe. You might see memory changes that interfere with a person's productivity at work or their ability to do chores at home, problems for the person maintaining or focusing their attention. The person becomes even more distractible than usual, difficulty adapting to change, and the language skills become more impoverished. In other words, the individual may speak less. They may use less of the vocabulary they once had, and they may have difficulty retrieving the names of objects or putting together sentences that make sense. And this is compared to what they were before, where they were capable of communicating at a more effective level. So what is your role as somebody who may be a rater for the EDSD? And by rater, I mean the person who completes it. Well, one thing you can do is assemble medical and background information before completing the form. You may want to confer with family, or if you're a family member, you may want to confer with staff to get their input before completing it. You may want to consider the areas in which you have observed that the individual has changed, but you also want to consider the areas in which the person has remained the same. That is valuable information as well. And you may want to place remarks in the comments section of the EDSD to add any important information that you feel would be in addition to what you've already endorsed on the rating scale. So we didn't ask every possible question we could have. And your experience may be that you observe change for your relative or the person you support in an area that the items don't reflect. So you want to put that in the comments section. So here's an example from page 3 of the EDSD. And you'll notice that there are several columns in which you're going to be asked to rate. Is it always been the case? Is it always but worse? In other words, always been the case but worse? Is it a new symptom in the past year, or does it not apply? Okay. And then you'll see that there are blocks of items, and in bolded area, it gives you kind of the category that we're looking at, the domain of functioning or area that we're investigating. So although it's not quite a Likert scale because we're not scoring it, the EDSD uses a Likert style rating composed of a series of 4 or more items that represent a range of choices for the same question. So beginning on page 3 and through page 4, you're asked to indicate for each item if it has always been the case, has always been the case but is worse, if it's a new symptom, or does not apply. The columns that are most informative on these pages are the new symptoms and the one that says always but worse, because that indicates or reflects change. The columns always the case and does not apply are areas in which you do not observe any change. However, as I said before, this is also informative because we want to know what the person is not changing in terms of their skill set, what they're still capable of doing. So let's consider what each of these tells us as a way of capturing observation of change. So in always been the case, so let's say Keenan has always needed help bathing. That's always been the case. It's always been the case that he does not initiate conversations. He's always sleeping excessive amounts of time during the day. By choosing always been the case for any item, you're indicating that this is usual and typical for the person. You've not observed any change in this area. Always the case, but worse. Rose has needed prompts to complete showering previously. Now she needs hand-over-hand assistance. Rose has always had mobility problems, but she previously used a walker and now she needs a wheelchair for anything further than short distances. She previously needed her food cut up for her, but now she can only eat finger food. By choosing always been the case but worse, you're indicating the person has lost more skills, is less independent in any particular activity of daily living, and which they already had a problem, excuse me, but the person is having increased difficulty in the area for which they were previously challenged. A new symptom, Walt has episodes of incontinence which began 3 months ago. Walt has become lost while walking home from his program twice within the past 6 months. Walt cannot remember the names of new staff members and is calling them by the names of workers who've not been at his home for several years. By choosing new symptom, you're indicating that this was not previously a problem, but it's a problem now and may be a sign of an important change. Does not apply. Joy does not need assistance in showering. She doesn't need assistance in dressing. Joy may have episodes of mild forgetfulness, but it doesn't interfere with her work or daily activities. By choosing does not apply, you're indicating this is an area in which Joy does not have a problem. So I want to introduce you to David and Sarah. Both are individuals with intellectual and developmental disabilities. They have different patterns of challenges and preferences with different support and service needs. Staff who are familiar with each of them have observed changes. And in Sarah's case, her sister has observed a change. The staff want to capture their observations of change by completing the EDSD and sharing their findings from the tool with their teams. So this is the time to take out, if you have access to the EDSD that I completed for David, to use it. So you'll notice there is a cover page. It's used to get background information about the person being treated. So, or assessed rather. So David is a 62-year-old male with mild intellectual disability and Down syndrome. He lives in an apartment in the community and is supported by SLL staff. What are some things that the information on the cover sheet might alert us to consider? Well, one of the things to think about as you look at the cover sheet is David is at high risk for Alzheimer's type dementia based on his age and the fact that he has Down syndrome. Page 2 is when you're being asked to rate the person in terms of their mental health and their physical health. How did it compare to last year? And items 16 to 18 looks at those individuals that have been previously diagnosed or have been diagnosed with mild cognitive impairment, which is not dementia, but for some people with that diagnosis, they later go on to develop dementia. Interestingly enough, David has been diagnosed with mild cognitive impairment in 2016. So what do we learn from page 2 ratings about David? Although the raters indicated David's health is good, they also indicated it is worse than last year. Compared with last year, he appears sadder and more anxious. Staff rated him as somewhat worse in his mental health compared with last year. We know David has certain sensory issues. He wears eyeglasses and uses hearing aids, but he's also had several stressors. A family member died, and his favorite staff left during COVID and did not return. And as I said, he was previously diagnosed in 2016 with mild cognitive impairment. He was not assessed, but it was based on his lessened productivity at work, less interest in keeping up with chores at home, and lessened interest in socializing with others. Pages 3 to 4 are going to be all the domains or subdomains we consider to do with activities of daily living and instrumental activities of daily living. So again, here's your choices. Always been the case, always but worse. New symptom does not apply. So what did we learn from page 3 in terms of what staff filled out for David? In terms of activities of daily living, well, he's independent in many of his activities of daily living. We know that because the staff is checked off the column does not apply for several items. However, he has been exhibiting a relatively new symptom of urinary incontinence. He's had accidents. Language and communication, David has displayed new signs of a change in his communication skills in the form of word finding difficulties. He often has a hard time retrieving the right word in real time in the course of having a conversation, and he tends to lose track in the middle of conversations. Page 3, we learn that he has several new symptoms. He's sleeping less compared with before, and he's waking up frequently. When awake, he appears confused. Staff have reported several episodes of middle of the night wandering from his home. And in terms of ambulation, staff endorse that he has gait issues and has fallen twice, although it was without injury. We know about his memory that he does not remember recent events in the past week or less. He does not find his way in familiar surroundings. That's a problem. He is losing track of time, day of week, seasons. He loses or misplaces objects. He has problems with learning new tasks or the names of new people. So again, if you have in front of you David's completed EDSD, you'll see this all under memory. Under behavior and affect, which is the block of questions with 24 next to it, we know that he wanders, he has increased impulsivity, he appears depressed, he withdraws from social activities, seems to go into his own world, and exhibits obsessive or repetitive behavior. So a lot is going on for David. According to what David says about himself, he says that he has changes in his ability to do things, and he's acknowledged that he has changes in memory. And staff have said, what a big change they've observed is in his gait, his tendency to stumble, fall, or be unsteady. Page 5 is where we have information from the Longitudinal Health for Intellectual Disability Survey from the University of Chicago. And you'll see there a list of conditions. And you're asked to recent condition in the past year, a condition diagnosed in the last 5 years, a lifelong condition, or condition not present. And we want to know about chronic health conditions because we know that chronic health conditions can also impact people's functioning, adults functioning with IDD. So what did we learn from looking at David's page 5? David's medical conditions include high cholesterol, hypertension, thyroid problems, depression, sensory issues such as hearing and vision impairment, and urinary incontinence. He has quite a lot going on. For further consideration, we might want to think, or the team might want to investigate, whether the high cholesterol and hypertension put him at greater risk for stroke and cardiac problems and therefore cognitive changes, and whether his lifelong thyroid problems, often an issue for individuals with Down syndrome, might be contributing to any of his observed mood issues. Depression, which he appears to have, can contribute to his concentration, attention, and memory problems. So again, here we're looking at conditions other than Alzheimer's disease or other forms of dementia that in fact may impact upon his functioning. His episodes of incontinence may be due to urinary tract or prostate problems, so that certainly should be investigated. But he also may be misjudging when he needs to use the toilet, and that is more of a cognitive issue that might impact upon activity of daily living. So some things to consider. And page 6 of the EDSD is where you gather information from the chart regarding the person's current medication dosage, when it's prescribed, any other background information that you haven't previously indicated, and other changes observed but not covered in the rating form. It also may be a place to look at next steps. So we know staff began to question about observed changes and wondered whether these represented dementia. What was this change in cognitive behavior and adaptive functioning that they saw? Ratings revealed several longstanding problems that need to be monitored and several new symptoms that need to be investigated and better understood for their possible role in his observed decline, including the possibility of sleep apnea. If you remember, there were quite a few things that staff endorsed regarding sleep changes, and individuals with Down syndrome do have a higher likelihood of having obstructive sleep apnea. David should be reviewed again in 6 months unless the signs of change worsen or he already receives a diagnosis of some form of dementia, Alzheimer's type or another dementia. So now we're going to go to Sarah. So Sarah's a 57-year-old female who has moderate intellectual disability. She lives with her relatives in her family home in the community. One thing to note is underdiagnosed conditions. Her family is her staff noted, not her family, that she has a history of bipolar 1 disorder, which is a more serious form of bipolar disorder. What are some things that information on the cover sheet might alert us to consider? Well, Sarah does not have Down syndrome, so we don't have that idea that she has a higher likelihood of developing a dementia, but her level of intellectual disability and her history of significant mental illness, and bipolar 1 disorder is a significant mental illness, may be factors in her observed decline. What did we learn about Sarah from page 2 rating? So I hope you're following along with me on Sarah's form. By the way, if it's highlighted in yellow, it is a new symptom. If it is highlighted in green, it means it is a long-standing condition, and that's not an area where there has been observed change. Sarah's relatives and staff rate her as currently having fair health, which is worse compared to last year. Sarah's mental health is about the same. We know she's diagnosed with bipolar 1 disorder. She has sensory issues. She wears glasses. And she's had 2 stressful episodes during the past year, including reacting to a change in her medications for her mental health disorder. At that point where she was having an adverse response, she was overly sleepy, drooling, and confused. And her meds were subsequently changed. And she's had a conflict with her sister and with the staff. In the comments section, staff noted they observed a change in several areas of functioning. What did we learn about Sarah from ratings on pages 3 and 4? Well, Sarah undresses sometimes in public, and she has word finding problems. She does not follow simple instructions. She sleeps later than usual, and she does not remember the names of familiar people. And I want to point out that her functioning in these areas seem to vary with her mood. So when she's depressed, or she's manic, which are the two extremes for bipolar disorder, these will variously impact upon her functional ability. She may show obsessive or repetitive behavior. She hides or hoards objects. She has increased impulsivity, touching others, arguing, taking things. She appears depressed. She shows verbal aggression and she shows physical aggression. She has temper tantrums and periods of uncontrolled crying and shouting. What did we learn about Sarah from page 5? Sarah has several medical conditions that may impact upon her cognitive and adaptive functioning. She has arthritis. She has cardiac disease. We know she has bipolar disorder. She also has diabetes and gastrointestinal problems. So what I want to point out is you'll notice an overlap. Some of the things that David is challenged by, Sarah is also challenged by, both within activities of daily living that have changed and in terms of health issues. With Sarah, she has two potential sources of pain, arthritis or discomfort, arthritis and gastrointestinal disorder, but she's not on any pain management regimen. She is diagnosed with bipolar disorder for which she's receiving medical management. It might be worthwhile to understand her current status in terms of her cyclic mood disorder. When was she diagnosed and initially treated? It could mean that she's been on psychoactive medication for multiple decades. Has her medication been recently reviewed? What are the non-medical ways she is supported for her mental health? So in looking at David and looking at Sarah, there's some things, we have question marks, we have some things we've learned about each of them. So what would we do if we're a member of their team in terms of using the findings from the EDSD? Well, we're going to ask questions to clarify any of the ratings or comments that there may be some questions about. We want to look for patterns. What are the areas in which change have been noticed? And to what extent? Is there something already that's been done to address identified issues? Or we want to bring the findings from the early detection screen for dementia to the team, the interdisciplinary team, the multidisciplinary team. In sharing with the members of the team, we want to reconcile any discrepancies across settings. We want to request any additional information that may be necessary and brainstorm possible approaches. We want to operationalize a plan of action, okay? So how can we best support David? How can we best support Sarah, given some of the things we learned through administering the EDSD? Is it time to refer either one of them to a healthcare provider or other professionals? And anything that we decide to do, we want to evaluate the effectiveness of. So what are some of the decisions that may follow from or informed by the use of the EDSD? Well, we may, decide that there needs to be some modifications within the person's residence in order to help them in accessing and be able to live comfortably within their environment. We may decide that where they're living is not the best place for them. They may need a change in residence. We may be thinking they need a change in their level of staffing support. Maybe they need increased supervision. They may need a change in their programming, might not be able to work anymore if they were working, or they may need to have their programming schedule changed. We might want to look at what a positive daily routine would be for them, depending on the skills that we want to support and what they may need help doing. and any items and activities for programming. So what are next steps for David and Sarah? What patterns did we find in their ratings, and how can we use the findings from the EDSD to plan and support services? Since David is at higher risk for Alzheimer's disease due to his age and Down syndrome, and remember, he was previously diagnosed with mild cognitive impairment in 2016, the IDT probably wants to refer him to the healthcare provider for further workup. The team might want to explore and investigate other areas that may be contributing to challenges for David. For instance, how might his hearing and vision be impacting upon his functioning? Because we know that sensory changes are very important in terms of ability to adapt to one's environment. The IDT may want to explore if he's a candidate for balance and gait training to prevent further falls. And it is possible there's some individuals who have depth perception problems as they age. This is particularly the case for individuals with Down syndrome. And might that be contributing to his previous falls and unsteadiness? The team will speak to David's healthcare provider about a referral for possible sleep study to rule out sleep apnea. And staff will consider helping David develop a positive daily routine by providing him with choices within a scheduled and structured day. So some of these things that we would be investigating, whether or not it will lead to a change in his functioning, it may indeed lead to a higher quality of life and satisfaction for him. What about Sarah? How can the IDT use the information from the ratings that were done in the EDSD to best support Sarah? Well, Sarah may be displaying cognitive, behavioral, and adaptive changes, and it looks like that is the case from her ratings. But unlike David, it's probably not due to dementia. It's probably related to her mood disorder. At least that would be my guess, based on the fact that her functioning varies depending on her mood. So we want to track variations in her mood as they may relate to her functioning. And that could provide us with very useful information about when she may need more support and when she may not need as much support, or ways to support her. Staff may want to refer her for a pain assessment to see if pain or discomfort through her arthritis and her gastrointestinal issues may be contributing to her observed changes. The staff will consider her support needs as they may vary according to her mental health status, and Sarah's family and team may want to explore whether she has adequate medication and non-medical treatment for her mental health condition. So there are both medical and non-medical ways of supporting Sarah with her bipolar disorder. So how might the use of the EDSD lead to a diagnosis of neurocognitive disorder, in other words, dementia? By ruling out other factors, the healthcare provider may recommend further testing and evaluation, and that moves the ball down the court in terms of getting a diagnosis. So although the EDSD is not a diagnostic tool, I know I'm being perseverative with regards to this, but I want everybody to realize it is not a diagnostic tool. The review of the findings may result in a referral for further diagnostic workup that can confirm or disconfirm the likelihood of a dementia like Alzheimer's disease or multi-infarct dementia, etc. So considerations for the use of the NTG-EDSD. Again, I know the tool's not for diagnosis. It's an administrative tool. And the diagnosis of neurocognitive disorder involves a medical exam and direct cognitive and adaptive testing of the individual in question. If the consumer is already known to have a neurocognitive disorder, that is dementia, you can still use the rating form to baseline observations of any additional change. Since this is an early screening tool, it does not need to be used continually if the person has been formally diagnosed with a form of dementia. So take-home messages: family and staff are the experts. You're in the best position to recognize everyday changes in memory, thinking, behavior, skills, and activity of daily living for people whom you know and support. The EDSD is an administrative screening tool that can be used to capture your observations of change, and the findings can aid and promote healthcare advocacy. Findings can be shared with members of the interdisciplinary team and healthcare providers to make decisions about services, supports, and treatments. Here's some references. And then do we want to take some questions?
And before we do that, Lucy, we would love to have your feedback on the webinar today. A link to the survey will also pop up in a separate browser window when we end the webinar today. But if you want to get a jump start on things while we're doing questions, feel free to scan the QR code that you see on your screen. Otherwise, there'll be a link when we close the webinar in a separate window on your browser. Could you go to the next screen, Lucy, because I think that one gives your email for follow-up questions. And with that, questions. Helen, do you want to handle questions?
I was going to say, we have a couple of questions here. One, very much a comment from an anonymous attendee, but who really is speaking to the point of the importance of sharing finding information of observations. So this was not so much a question as a statement, which says, I have shared this information and findings in ISP meetings for baseline of a 44-year-old with Down syndrome. As a parent, I want all to be aware of change. So this individual, Lucy, was clearly speaking to the importance of, when we're talking about the team, that it's the greater team. Do you want to speak a little bit about who you would want information shared with, Lucy, when someone is using the EDSD?
I mean, first, it's within the team. So, and then the team decides, I think, if this is time to kind of move the person on to another referral to another professional. Like, on the basis of these observations, do we have enough here that we think we want to share it with a healthcare provider or refer it to somebody who might be doing a dementia assessment if there's somebody locally who's doing that? So the healthcare provider, the kind of information you would share is a summary of where you have seen the changes, perhaps since the last time the person has gone to see the healthcare professional. Because obviously, you're not going to share the entire form with the doctor, but you're going to just highlight what it is you're concerned about, even if it's in the form of question. We've observed changes in these areas, and we're wondering what might be causing it. Where can we get some more information about this? Would there be further testing? Whether it's labs, whether it's kind of an evaluation, where do we go from here? So it's usually the healthcare provider that would be the person with it once the team has discussed. And then in terms of supporting the individual, again, there are multiple decisions having to do with where the person lives, any accommodations in the environment, any kind of staffing considerations, programming considerations that the team could make, even if the person doesn't have a diagnosis or winds up not having a diagnosis of a dementia. It could be useful in just thinking about how to tailor services to the unique needs of this individual who has changed regardless of that reason, whatever that reason might be.
Thank you, Lucy. Robin is asking the question, how do you differentiate between dementia and Down syndrome regression disorder? Could you speak to that?
Well, Down syndrome regression disorder is usually for much younger individuals. So we're not thinking about somebody in their 20s, for instance. that is, and that's Down syndrome regression disorder, usually a young individual. But somebody who's over the age of 50 who is showing signs of change, that would be more likely indicative of the possibility of dementia. So, I mean, but they would have to be evaluated because, again, there are many possible causes of change, cognitive, behavioral, and adaptive change. And we want to, that's where differential diagnosis and ruling out various things that could be contributing are important. So there's no hard and fast rule of saying, is it this or is it that? It has to be taken on a really individual basis. Yeah.
A couple of people are speaking to the issue of finding healthcare providers who are knowledgeable around both capturing observations of change and understanding what may occur with people with an intellectual or developmental disability. Do you want to comment on the issue of where do we find the right specialists that we need when we're needing to interface with the healthcare provider?
Yeah. Well, that is, I wish I had a good answer
I
for
know.
that, other than to say, if you want to visit the NTG website, there is material that can be shared with the healthcare provider, written by medical professionals, talking about things that the aspects of this that are highlighted in medical terms that could be appreciated by a physician. So, very hard, and we're making some progress with medical schools that are actually incorporating information about this in their curriculum. So it's a process, but I don't have any, people are coming from all over, right? Hard to say how to find
I was going to say, very tough. Certainly, the resources of the NTG and the NTG website has been posted several times in the chat. www.the-ntg.org is a great place to go to start. If we have an extensive network of individuals around the country and in North America and beyond, and would be happy to try to connect individuals if you had someone in particular that you were looking for assistance with trying to get connected to the right resources. One of the things related to this particular webinar and subsequent webinars that will be offered in early 2026 is the development of the guide model under Centers for Medicaid and Medicare Services, and that a coordinated approach to dementia care, not only for the individual with a disability, but for their caregivers, is the focus of the guide program. And we are working very hard under this particular project to increase the understanding and readiness of the guide caregivers, to guide healthcare organizations to be ready to support and work with families of individuals with intellectual and developmental disabilities and the individuals themselves in terms of care and diagnosis, and the right support plan for that individual going forward.
I put the barcode back up because there was, yeah, thank you.
And it will also pop up in a separate browser window when we end the webinar as well.
We have many, many comments, and thank you all for the comments regarding the value of this particular webinar topic. We do have 2 webinars coming up in January and February that will be related to really brain health and healthcare advocacy for all abilities. And there'll be information about those dates and those presentations that will be posted on the NTG website, probably in mid to late December. The webinar dates will be late January and late February. So stay tuned to the NTG website for more information on what's coming next. Dr. Ezralu, on behalf of everyone, we just want to thank you for your tremendous information today. It really has been exceptional for all of us who have been part of this, and for all of you who have attended on behalf of the NTG. Yes, observation, capturing observations of change. You are the observers. You know your family members are the people you support best, and you are a powerful voice in bringing together the resources that will support them to have a quality of life in terms of what will happen next. Final words, Catherine?
No, just thanks everyone so much. I was just responding. We did have questions about the recording, and it is being recorded, and a link to the recording will go out within 48 hours to everyone who is registered. So you will get that. I'll also be sure that I put in a link to the blank NTG-EDSD. We'll send you a copy of that, as well as another link to the NTG's website. But if you want to look at it before that, go to the NTG website, www.the-ntg.org. And right at the top of the page, you'll see running across the top some little tabs, one of which says EDSD. And if you click on that, you'll get all the information you need, the translations and everything. It's free, and we want people to use it. So please visit that. And visit the other pages on our website as well, including the one for the guide program. We have lots of information on the guide program there as well. So just thank you, everyone, and we look forward to hopefully seeing you all next time. You'll all get invitations by email when we get the next one scheduled, and we look forward to having you all join us. Thank you, everyone. Have a great rest of your day.
Bye.